everybody. My name's Carmel McCalmont. Okay. My name's Carmel McCalmont and this is Mary Passant, and we're from the Birmingham and Solihull United Maternity and Neonatal Project, which is called BUMP, but we are actually the Birmingham and Solihull Local Maternity System. So we're here to tell you a little bit about the project and what we've been doing over the last few years. I've been in post since December last year and Mary since about March. Yeah. And the team that were in place before us were amazing, and they set all the foundations of the work that we've continued to do. But we've, it's on there now, but it's not with you, so as soon as you get it, we'll move on. Great. So we're here to tell you a little bit about what we've been doing, and we're really in a fortunate position because we are an early adopter and a pioneer. And across Birmingham and Solihull, they made a decision that they wanted a team to run this project and not do it as part of the day-to-day job. So they appointed me. My background is I was a head of midwifery. Do I practice? I do a clinical day a week, a clinical day a month, every single month. And the reason that I do that is I moved from Coventry, where I was really established, to Birmingham, where I knew very few people. And to get to know the midwives and have them on board and to move things on, you have to be there, you have to prove yourself. So I love working clinically, and I'm really privileged to still be able to do it. We also have a medical director called Richard Kennedy, who's phenomenal, and a director of operations, and a whole project team behind us to do this work, which is really, really helpful. So the first picture here that you can't see, we're just about to. So what are we all about? We're here for the women, the families of Birmingham and Solihull and of the whole country. It's really important to us that our women get the best experience that they can, and we really like to take feedback. So just a little bit of an overview for us. We're just going to talk a little bit about the drivers for change, maternity transformation, and where we are as a programme now. So as you all know, the National Maternity Service Review was published in February 2016, and it is the biggest maternity policy that's been published since the 90s, and it's a massive opportunity, and it's not the 1990s policy being revisited, but for some people they still think it is. So we've got to really modernise it and make sure that we're doing the right things for women. We also know that we've got to reduce our stillbirths, maternal deaths, neonatal deaths and brain injuries. We've just got to do that. And the Saving Babies Lives Care Bundle and all the work we've been doing through the Maternity and Neonatal Collaborative should work towards that, but we've just got to keep on that because that's really important. We know that perinatal mental health has been the poor relation, and we've really got to support our women there. The payment system James has spoken about, and we'll talk a little bit about that later on. And we really need to keep our eye on the ball with public health to improve women's health before, during and after pregnancy. Mary's going to take over now and go through a few slides, and I'll just interject now and again.
Yeah, so just to talk about where we are now. So within BUMP we're developing a single point of access, and I know across the country single point of access means different things to different people, but to us it means access to maternity services across our patch. We decided not to go with a big bang. We decided to pilot a system and then roll it out in phases. So from the end of this month, our single point of access will be being piloted across our patch. The single point of access is a way women access maternity services electronically, and we know from our research that at the moment still 85% of our women first point of access when they're pregnant is to see a GP. Their GP will then tell them that they will tell their GP they're pregnant. GP will then refer them to a local maternity system, or the GP might send them away for a couple of weeks because they're so early pregnant, so then they have to make another appointment and see a GP. So there's a lot of waste in our systems already. With our single point of access, our aim is that the woman will be able to self-refer. She'll self-refer into the LMS, and we've done a lot of work with our GPs, pharmacies, midwives, community midwives, and our MVP about what it should look like and what should happen after the woman's first accesses the system. So the aim is they'll get the normal information, and if they're a normal care pathway, they're not a high-risk pathway, information will go to the GP to say they're pregnant, so we'll tell the GP they're pregnant, and also information will go to the midwife, who'll then make an appointment to see them. And our aim is at that appointment the women will make the choice about their place of birth, so they'll have an informed conversation before making the choice. If they're on the high-risk pathway, the same things will happen. They'll still the GP letter will go out, they'll get an appointment with their midwife, but they'll also be put onto their appropriate pathway. Once they access the system, they'll also get information about our facilities, videos about each of our units. So we're going to start giving them information really early on, because women really like to know, don't they? They want to know what's going to happen next. So as I say, that will be piloted at the end of this month, and we're hoping to go live early next year. And we're talking to our local NMSs, and we're hoping this will become a West Midlands system, not just a Birmingham and Solihull one. We're piloting 2 community hubs now, one at Solihull Hospital and one at Lordswood, which is a GP surgery, and that's going really well at the moment. And we've implemented, one of our biggest challenges was to implement a single maternity IT system across BSOL. That's now in place for antenatal, and it's going into place for interpartum and postnatal early next year. And that's been a real challenge, but actually the benefits of that are already there. So wherever a woman is within our hospital services, then the system's there, and they also have access to their own records, so that's worked really well.
So one of the biggest challenges that we've got with Better Births is continuity of carer, and we can talk about it as much as we want to say we're doing this and we're doing that, but if we're actually going to roll it out over the whole pathway, it is a real challenge for us, and I don't think we're going to fix this in a few months. I think we need to be really realistic about it. So we haven't gone big bang in Birmingham again with continuity of carer. We've tried to take our midwives, obstetricians, doulas, everybody with us around that, and we've looked at different pilots, and we've been doing that for over a year, and we've had 13 different pilots that we've been trying. So we've tried a pilot, if it's worked, we're trying to roll it out, sustain it. If it hasn't, we've gone back to the drawing board, and we've definitely got the midwives and everybody involved. And continuity of care isn't just about midwives, and that's what we've focused it back on. It's about obstetricians who see their women through the whole lot. We've got an amazing project going on at Good Hope Hospital in Birmingham, where they're diabetic women. They have a big diabetic cohort of women. They're seen by an obstetrician, a diabetologist, 3 midwives are in that clinic. They see those women, they give them continuity of care, they scan. Those midwives also work in the delivery suite and in triage, and they try to follow their own women through. So yes, it is a bit ad hoc because it's a team of 3 midwives and obstetricians, but actually where women are having elective sections or where women are being induced, they are very often seen by those midwives. So we're just evaluating that at the moment, and we're just crunching the numbers. So collecting the data around continuity of care is a challenge in itself, but Badgernet will do that for us, and we hope by the end of January we'll know where we are exactly. In July we were around about 10% continuity of care booked onto the pathway, and we're trying to be realistic. We're not trying to say we're doing things that we're not doing, because that's just pointless. We've got a number of pilots going on in birth centres where we're trying to be innovative. We've got a home birth team, and we put a new leader into the home birth team in March, and he has worked really well with the team to increase our home births from 1.4 to 2.4% since March, which has really been helpful. They're small numbers, but they're amazing. Having a really good relationship with the heads of midwifery is crucial to this. So I work with the heads of midwifery, I don't manage them, I work with them. And one of the heads of midwifery has, on one of the organisations, has just put 2 midwives into the home birth team. So it's a true LMS home birth team, so that we can increase our reach. So we'll be piloting that against the traditional team of community midwives going out to their own women. So we've got a number of pilots going on, but I won't talk any more about that because we're a bit limited for time. But just a little bit about personalisation and choice, and Mary's going to show you the next slide shortly, which will show you where we are with that. So we've been registering on Badgernet personalisation and choice conversations since we went live in July, but prior to that, part of the system was in one of our organisations. And in March, when we had to reach the 10,000 personalisation and choice conversations in Birmingham and Solihull, we reached 8,000. So we're well on the way now. Every woman has a personalisation and choice conversation. We also piloted the personalised maternity care budget conversation, and we only did that with 25 women, but also our colleagues in Cheshire and Mersey did the same. We had the same kind of results from that. So some women really liked being told about the money and what was happening with the money and what they could do with it. But actually the only choice they have is place of birth. They don't have a choice to go out and have reflexology or aromatherapy, because if it's not in your organisation you can't offer it, but we do have that, but that's by the by. So, but some of the women said to us, if I don't spend all of my money, what will happen to it? Will I get a refund? If I elect for the low risk pathway and I need a caesarean section, will I refuse it? These are real concerns for the women. So because the numbers were small, we made a decision that we would move this on. So we've currently got an academic looking at the personalised maternity care budget with our women, and through our MVP she's doing focus groups so that we can get a bit more rich information really, so that we can feed that back. We've developed a suite of shared guidelines and care pathways across the LMS. So our LMS guidelines say bump on them at the moment, but they'll say LMS in the future. So as a guideline expires, we replace it with an LMS guideline, and that's gone down really well. And we're doing a lot of work around improving prevention and early intervention.
And this is my favourite slide. This is our personal care plan, and this is just one of the slides just to show you how that works, and we're being hurried up, so I'll have to go really quickly. And so every woman will have access to her personal care plan, and every week it'll give her updates. She can put her own photo, or she can put a picture of a cat in if she wants, it's really up to her, or she can plan her own development. Each week it'll give them a summary of what should be happening to baby at this stage and the things to look after. It'll give them their appointments. They can go on the top and see their medical records. It'll give them all their blood results. It will stop. What it won't do is if there's blood results they haven't been told about and there's a problem, they won't get those until they've had that conversation. They can plan their own journey, they can put things in themselves, and they can go, it'll have lots of links to different information they need at that stage of their pregnancy. So this will go live early next year to all of our women, and we're just really pleased with it. We've worked with Badgernet to make it as user friendly as possible, and I'd like to talk more about it, but I've been told to hurry up. So we can just really go through our priorities, and that is to improve perinatal mental health, to collaborate. We're working really closely with our neonatal colleagues, and we have a neonatal working group as part of our LMS, because actually, you know, it doesn't stop when the women give birth. There's a lot of work to be done, and we're also starting to work with health visitors as well. We talked about, we've had a lot of, we're sharing our clinical and corporate governance system, and that's been really challenging across our organisation. So it's taken us probably 6 months to get an agreement to share our data and to share information. So if anybody wants our paperwork, you're more than welcome, because we hate you to go through the pain we've been going through. We're working really closely with our Maternity Voice partnership, and that was set up as a
so we've got a third sector organisation, and we've moved from a number of NSLCs to one MVP across Birmingham and Solihull.
Yeah, and we're in negotiation for our CCG to carry on funding that at the end of the programme. And you know, we have, like everybody else, an ambition that we have wider technology and remote monitoring. But as Carmel said, you can have all of that, but you still need to put your hands on a lady.
So I'm just going to do a whistle stop of the last couple of slides. So we've had lots of, I'm not going to even go through that. We've had lots of reach with our women. We've done lots of events. We've spoken at lots of events across the country, and we're holding events for our staff. We got £25,000 for the workforce monies from HE. Thank you so much. So we're developing link workers, and this morning we've got our money for the continuity of carer training. So we're really delighted with that. But just long term, we've aligned our vision with what we're doing across Birmingham and Solihull STP, and we've tried to use the same KPIs as they are, and there's lots of things we're doing there that you can see, and I'm happy to share the slides, but I'm not going to run over. So one of the things for us is that when we came in, people had lots and lots of ideas about what they wanted to do, but they hadn't done things like talk to the booking clerks about how they do things and their processes. So we mapped the work that goes on across all of our organisations, and it was huge. So we got our booking clerks in a room, and they have absolutely supported the work that we're doing around single point of access, because we wouldn't have done it without them. And they feel so involved and so empowered. But just for us really, change will not come if we wait for some other person or some other time. We're the ones we've been waiting for. We're the change that we see. Thank you.